So, good morning all. So, my first abstract is a single fraction stereotactic versus conventional multifraction radiation for predominantly non-spine bone mates, a randomized phase 2 trial. We don't have robust data single fraction RT for non-spine bone mates, but still few literature have suggested that single fraction RT is equivalent to multifraction RT. Multifraction RT suggests that 20 grain 5 fraction or 30 grain 5 fraction, 30 grain 10 fraction. But in spite of this, higher single fraction RT results in higher retreatment rate. Some literature has shown is 2.5 times. However, it is also less expensive and more convenient for the patient. All the clinician in this world is very much familiar with multifraction regimen in 1310 or 20 grain 5 fraction, and more comfortable, and patient are, and also physicians are more comfortable with long-term outcome, and it is also durable. A previous study, RTOG 971 study, this included patients with breast and prostate cancer. Almost 900 patients were randomized in 8 grade single fraction or 30 grade 10 fraction to see the clinical effect as pain and narcotic relief in patients with variables as complete, partial, stable response. Secondary outcome was there were retreatment rate, quality of life, toxicity, and fracture. The clinical outcome between two fractionation regimen, that BPI means that brief pain inventory score, was not significantly different between the two arms. Also, overall response as complete, partial, stable, or progression, there was no difference. If we take the survival outcome between two fractions, median survival was 9.1 in 8 grade and 9.5 in 30 grade 10 fraction. Also, complete objective response, orthonorcotic, pathological factor, retreatment, toxicity was no difference between two arms. The conclusion of this previous study was 8 grade was as equal to 30 grade 10 with pain and narcotic relief. However, there was similar rate of pathological fracture, but 30 grade 10 with more toxicity and also retreatment rate in single fraction was higher. In 2007, a systemic review, which included 16 trials from 1986 onwards, this pool data shows that there was no statistically significant difference with single fraction in terms of objective response, complete response, pathological fraction, cord compass. However, retreatment rate with single fraction was 2.5 times compared to multifraction. So now coming to the current study, which is single fraction SBRT versus conventional multifraction SBRT for pain relief in patients with predominantly non-spine bone mates, we included 163 patients, randomized 160 patients. In 79 patients were treated with multifraction regimen and 81 to the single fraction regimen. So primary objective to evaluate single versus multifraction in terms of pain control, and also secondary objective to prospectively report pain, quality of life, orthonorcotic, acute and late toxicity, local control, survival, and re-RT as salvage surgery in later course of time. If you see the patient characteristics, there was most of the patients, the primary include breast, esophagus, head and neck, liver, lung, multiple organs, pancreas, prostate, and renal cell carcinoma. So total 160 patients, 79 in 30 grade 10 fraction. In SBRT arm, total 81 patients were stratified with dose with 12 grain single fraction, dose of lesion more than 4 cm. And for patient with less than 4 cm lesion, the dose was 16 grain 1 fraction. The PTV was GTV plus 5 mm margin. So if the clinical outcome as pain response over time, but per protocol analysis, if we see that patient who received single fraction over multifraction, they are well responder at 2 weeks, also at 3 months, and also 9 months, and that was statistically significant in single fraction compared to multifraction arm. If you see at 2 weeks, it is 62% in single fraction, 36% in the multifraction arm. If we assess the intention to treat analysis, the patient who received single fraction have got better responder at 2 weeks and also 3 months compared to multifraction arm. If you see the progression-free survival in the SBRT arm, 2 years, at 2 years, PFS was completely 100%. However, in multifraction, it is 90% on 1 year and 75% at 2 years. If we assess the re-RT rate in those patients who are treated, 2-year re-RT rate in SBRT was 0% in the current study. However, in multifraction, it was 5.3%, where the difference was not statistically significant. If we compare the similar result, the present result with the previous bone pain trial 1992 to 1997, that shows that 1 year re-RT rate is double in single fraction compared to multifraction, 8 rate to 20 grain factor. One of the possible cause could be because the less BUT dose given in single fraction arm compared to the current arm, which is given a higher BD compared to that bone pain trial. So I think that could have translated equivalent result between the SBRT and multifraction arm. If we assess the toxicity between SBRT and multifraction, the dermatitis was still grade 1 and not more than that. The other toxicity, nausea, vomiting, was also limited to grade 2 mostly, and grade 3 were very few. However, one patient, the SBRT was very gratifying. The result, the patient presented with acute urinary incontinence and loss of sensation. After being 12 grains single fraction SBRT, urinary sensation was regained, function was regained, removed, Foley's catheter was removed after 3 weeks. So in conclusion of this study, the higher dose single fraction SBRT results in more durable pain response compared to standard multifraction 20 grain 5 or 30 and 10, and should be recommended for patients with good KPS or with long life expectancy. This is minimal toxicity, safe and also effective treatment, and higher dose of SBRT could be in future could be a standard of care for bone metastasis. Though at present we don't have a much robust data, and so RCT with high ability dose as SBRT with combination of immunotherapy or combination of chemotherapy is need to be evaluated in prospective study in future. Thank you for my